Curious Clinicians, a medical podcast that asks why. I'm Hannah Abrams, and I'm joined, as always, by Avi Cooper and Tony Brew. All right, Tony, what have you brought us for today?
Get going.
Well, yes. This one came from, I think I saw it in one of them like journal watch type things. That I was perusing my inbox, my email inbox, and I came across an article in my inbox, and the article was written by Matthew Groudon. And Dr. Groudon is a geriatrician at UCSF. But I knew Dr. Groudon when he was rotating as chief resident at my hospital. And I saw this article, and I saw that Dr. Groudon was the senior author on it. And I got super excited and read the article, and I wanted to bring the article here, share it with you guys, share it with the audience, and sort of all the implications of what I read. So anyway, the article was entitled, Which Older Adults Are at Highest Risk of Prescribing Cascades? A National Study of the Gabapentinoid Loop Diuretic Cascade. So kind of a mouthful, but it also tells you exactly what they did. And we're going to get into that specific cascade as part of this episode, but it might make sense to sort of take a step back and just talk about prescribing cascades more generally first. So it's not something I had necessarily come across before seeing this article. I'm not sure if you guys have heard this term before and have encountered the idea of a prescribing cascade.
I think sometimes my life feels a little like a prescribing cascade because in oncology, we're prescribing so many drugs that have so many side effects, and then those side effects need to be medicated, and then the side effect medications cause their own side effects, which require medications. Just like, for example, I think about patients who are on opioids for cancer-related pain and then need a bowel regimen for constipation, but are also nauseous, and the nausea medications cause either diarrhea or constipation. So this feels, this hits close to home for me, but I hadn't heard of this prescribing cascade. So I'm excited to learn more.
Avi, I have to imagine there's some in your practice that you see.
Yeah, certainly not as complex as the regimens that Hannah is prescribing. But the one that comes to mind for me, and from a pulmonary standpoint, would be anti-fibrotic medications, which have, unfortunately, a lot of gastrointestinal side effects. Often to the point that people, up to even some, a significant portion, have to stop them because of GI side effects. So, nausea, vomiting, and diarrhea. And so often prescribing medications to, for anti-emetics or antidiarrheals to be able to tolerate them.
Yeah, these are great examples. And the one I remember most from my time as a resident was the patient who was getting IV furosemide, who then a few hours later needed potassium supplementation, right? This is I don't know, at probably half the orders I wrote as an intern, in addition to the bowel regimen, Hannah. But so broadly, prescribing cascades occur when one medication causes side effects that are treated with a second medication. And that's exactly what the two of you described. And they happen all the time. And as the article by Dr. Groudon alludes to in its title, what they specifically looked at was a particular prescribing cascade in which gabapentin and similar medications lead to the prescription of a loop diuretic.
So this is maybe a leading question, but what side effect is gabapentin causing that prompts the use of loop diuretics? Might it be edema?
Yes. I mean, there are a few things you might imagine they could be treating with a loop diuretic, but I would say unsurprisingly, edema, more specifically peripheral edema, is what they were finding, or what I think has been most reported. And I'll be honest, I care for a lot of patients who are on gabapentin, and I hadn't actually heard of this side effect before I came across Dr. Groudon's study. This is not something I was aware of. And the mechanism is super interesting, and it actually has implications for the management of this side effect. So that's one of the reasons why I wanted to share it on the show. Maybe I'm totally naive in not realizing that this a side effect happened. Is this something that you guys had sort of maybe heard about before me, that gabapentin is associated with edema? There's a lot of medications we associate with edema, but this isn't one of them.
Yeah, I was gonna say like calcium channel blockers and things like that.
Right.
But
Yeah.
yeah, I personally had not heard of it.
Yeah. I would have thought like Lasix for daytime somnolence, maybe, or furosemide for daytime somnolence. I don't know.
Prevent falls.
Yeah.
Sure,
exactly.
probably. I think that furosemide can do just about anything. That's what I learned from medicine residency.
It really is a wonder drug, and we've talked about it on the podcast before.
Episode 24.
It does a lot of wonderful things, but it certainly does lead to a diuresis. But gabapentin and edema. What's interesting is this side effect has been recognized since the earliest trials, and the earliest trials were actually for postherpetic neuralgia. And so, a 1998 RCT that was published in JAMA that reported edema in 10% of those receiving gabapentin versus 3% for placebo. So this is, again, one of the earliest trials of gabapentin. And we've accumulated, as you can imagine, scores of papers subsequently. And so we now have the ability to meta-analyze it. And, Cochrane has done that. And they report that edema occurs with about 7% of patients receiving gabapentin versus 2% for placebo. So not an astronomically high value, but certainly a high number. And for those of you who may be interested, you don't see this with just gabapentin. You see it with other gabapentinoids, including pregabalin.
Wow. Yeah, it's not an astronomically high percent, but if you multiply it by the probably 100 million people who are on gabapentin I don't know how many people are on gabapentin, but that's like a lot of people, it seems like. Seems like a lot of edema.
Yeah, I wanted to understand the magnitude of the problem, so I said, okay, let me look at GoodRx and see where does gabapentin rank in terms of the most commonly prescribed medications in the United States. And I thought, maybe it would be in the top like 30, 40. It's number 6, which kind of shocked me. And I don't know. I'm going to ask you guys to play along and try to guess maybe what the top 5 are. So what beats gabapentin in terms of prescriptions in the United States? And this data, I think, is from like 2022. What do you think, Hannah?
Atorvastatin.
Yeah,
okay.
There's got to be
Perfect.
a statin.
Atorv is number 1. Yep, Atorv is number 1.
Good. That's all I can say to that.
All right,
like
one of them is
HCTZ?
yours, Avi. Oh, okay. HCTZ. Albuterol is number 3. Antihypertensive, that's not HCTZ,
Ooh,
so
maybe
lisinopril.
Oh, lisinopril.
Good. And amlodipine is number 5.
Yes, I feel like I'm on Family Feud.
I know. The
Was that
only
all
one
of
that
them?
No, the only one you're missing is levothyroxine. Kind of surprises me that there's that much hypothyroidism. So Atorva
Really?
1.
I feel like it's everywhere.
That's a 33% prevalence in this podcast population.
Apparently. That I didn't know. But okay, so we got Atorva 1, lisinopril 2, albuterol 3, levothyroxine 4, amlodipine 5, and gabapentin 6. And that's GoodRx. There are other resources I came across that had it listed as 10th. But even if
It's
it was
high.
It beat every antibiotic.
Yeah, and it beats a ton of stuff. So, Hannah, you alluded to this, that, maybe it's not 100 million people, but we're talking about a lot of people who were potentially causing edema even if the percent incidence is only 7%.
Wow. So I suppose coming back to the idea, the original paper from Dr. Groudon, how many of those people are getting a loop diuretic and we didn't even know it?
Right. So how often is the cascade actually happening? Yeah. Right. Because not every patient with edema necessarily gets loop diuretic. So what their study did is they examined 10 years of VA and Medicare data. And specifically, they looked at the 6-month period before and the 6-month period after the prescription of gabapentin or pregabalin. And they wanted to see the rate of loop diuretic prescription and how it changed in that 6 month before and that 6 month after. And what they found is an adjusted sequence ratio of 1.23. And that, I guess, strongly suggests a prescribing cascade.
Can you please explain what an adjusted sequence ratio is?
Snip for me.
Yeah. So
that does not. I do
Does not
not know what
compute.
that is. That does not compute.
Yeah, I'd never heard of prescribing cascades. I had never heard of gabapentin associated edema, and I certainly had never come across an adjusted sequence ratio. So Dr. Grant's article was kind of like eye opening for me in multiple ways. Um, so anyway, this is a tool that's used to identify side effects from medications. And in this case, the adjusted sequence ratio was calculated by comparing the rate of loop diuretic prescription before and after gabapentinoid initiation. And then they generate a ratio to demonstrate the change. And so the plain language way to interpret an adjusted sequence ratio of 1.23 is that loop diuretics were initiated 23% more often after gabapentinoid initiation than before. So 23% more often, I think that's kind of a lot.
Yeah, it's also interesting because the edema rate is 7%, and I don't
Right.
know how much, how severe does your edema have to be to qualify on whatever clinical trial metric versus what you see in clinic. But
Right.
that that's pretty striking. So I mean, it seems
Yeah.
like, kind of recapping where we are so far, gabapentinoids seem pretty safe. It seems pretty safe to say that they are associated with edema, and that as a result, there is an increase in prescription of loop diuretics in patients who have recently been prescribed gabapentin. So, when's the edema? Where are they? Sodium retention? How is this coming about?
Yeah, that was my initial assumption, was that there was something they were doing something and it leading to sodium retention at the level of the kidney or elsewhere. And so it would make sense to give a loop diuretic. Um, but it actually doesn't appear, based on the whatever data it is that we do have, and we don't have a ton, but it doesn't appear that sodium or fluid retention is actually the problem. And one of the things that suggests this is that loop diuretics don't appear to be effective at mitigating gabapentinoid associated edema. And if that's the case, it suggests it's maybe less about retention of salt and water and potentially more about where that salt and water are in the body. Um, and you actually see a similar issue with calcium channel blockers, where loop diuretics aren't that effective at mitigating the edema that you see with those agents. They can help, of course, but probably not as much as with a sodium retention state. And so, the question then becomes, and you ask this, Hannah, like, okay, well, what is the mechanism if it isn't sodium retention? And I think the leading hypothesis right now is that gabapentin affects what's called myogenic tone, and what's downstream of that is ultimately the edema.
Well, maybe before we get to myogenic tone, so if the edema from pregabalin and gabapentin does not respond to diuretics, it's not driven by sodium retention. That implies, Tony, that the prescribing cascade is not warranted.
That's right.
That it's actually like it's unnecessary. I mean, you're sort of exposing the patient to. You're taking a euvolemic patient and giving them
A thing we do for no reason.
yeah, a thing. Yes, exactly.
Trademark.
A loop diuretic.
That's exactly right, and potentially you're putting them at risk for harm because you're taking a euvolemic patient who you're now diuresing potentially to hypovolemia. So this is where I think an understanding of mechanism of side effects becomes relevant, because the better thing to do is to attend to that mechanism or discontinue the drug.
Yeah. So no, that's really helpful perspective. And so going back to myogenic tone, so that right is like the ability, the intrinsic ability of our blood vessels, like our arteries and arterioles, to sort of vary in size, to get smaller or bigger in response to, like, changes in pressure, right, in the
That's
lumen.
right.
And so is that sort of what that is?
Yeah, and what's interesting is that this response is sort of myogenic tone, myogenic response is independent of sort of the neural and the hormonal influences, and it's pretty fundamental to the regulation of blood pressure and blood flow, particularly at the level of the capillary. And so, if any of us were to stand up, um, myogenic tone helps to prevent an increase in capillary hydrostatic pressure and ultimately edema formation that otherwise might occur as a result of gravity, right? So if I stand up, there's increased pressure in my legs, in the vessels in my legs. And if I didn't have myogenic tone, that increase in pressure would be felt by the capillaries, and hydrostatic pressure in the capillaries would increase, and I would have edema. But what happens in a normally working blood vessel is I stand up, the pressure increases, there's vasoconstriction of the of the arterial, not afferent, we're not talking about the kidney, of the arterial, and that helps to protect the capillary from that increased pressure. So with gabapentinoids, it turns out that they lead to a reduction in arteriolar myogenic tone. And these medications, gabapentin, pregabalin, they're high affinity ligands for the alpha 2 delta subunit of voltage gated calcium channels. And the key thing to know there is that what happens then is that when there's binding to these voltage gated calcium channels, that leads to a decrease in myogenic tone of the blood vessels. That leads to an increase in capillary hydrostatic pressure and ultimately movement of fluid across the capillaries into the interstitium. And the clinical manifestation there, of course, is edema. So, the mechanism is a little bit more complex than simply, I'm retaining sodium. But it also ultimately makes sense that edema might form if you have a reduction in this. This is also, by the way, what you see with diabetes. Diabetes, just in and of itself, can lead to edema, and the mechanism there is felt to be partly related to the decrease in myogenic tone.
Yeah, and it sort of elegantly works together with the idea that gabapentin primarily works on nerve and sort of neuromuscular hormonal signaling as compared to something that wouldn't quite make as much sense like salt retention.
That's right.
And it seems like this is a little bit more similar to, like you mentioned, amlodipine causing edema, which I imagine
That's
is
right.
also a prescribing cascade.
Yeah.
Um, but and is that pretty much the same mechanism?
It is. With the calcium channel blockers, there's a little bit more to it. But as you said, Hannah, amlodipine and other calcium channel blockers are definitely a class of medications known to cause edema. And with gabapentinoids, they decrease myogenic tone. And one study they came across found that gabapentin and pregabalin actually decrease myogenic tone to the same extent as verapamil and nifedipine, two calcium channel blockers that do the same thing.
So, gabapentin, if it's having this decrease in myogenic tone, sort of similar to calcium channel blockers, is gabapentin like an effective medication to lower blood pressure?
Yeah, I wondered the same thing as I was reading all this. I was like, wait a minute, is gabapentin an antihypertensive? Should I be
Add it
worried
to the
about?
armamentarium.
Yeah, or should I be more concerned about supine hypotension with this drug? And I couldn't really find evidence to suggest that hypotension, at least supine hypotension, is a side effect of gabapentin, though there is an association with orthostatic hypotension. Now, I will say that one of the studies I mentioned earlier found that gabapentin and pregabalin, they did not induce significant vasodilation compared to the control group. And remember that verapamil, nifedipine, that's the mechanism by which they lead to a reduction in blood pressure is vasodilation. So with calcium channel blockers, it's probably the case that they lead to edema not just from a reduction in myogenic tone, but also via a reduction in an increase in arterial or vasodilation. Both of those lead to increase in capillary hydrostatic pressure. And I'd offer that this also may explain why calcium channel blockers are associated with higher rates of edema than gabapentinoids. So, to put a number to it, in one meta-analysis, the incidence of edema with calcium channel blockers reaches up to 24% at 6 months. And you compare that to the 7% I mentioned earlier with gabapentin. So I also mentioned earlier, and I don't think this is going to surprise anybody, there's also a very clear prescribing cascade where amlodipine leads to loop diuretics, just as what we see with gabapentin. So the mechanism here is with calcium channel blockers is also not sodium retention. So the diuretics probably aren't helping, which is unfortunate for the people who do get prescribed them.
I did have one sort of final spare key for gabapentin, sort of another surprising, and I think even less poorly understood side effect or potential side effect. And that's that there seems to be some intriguing data around an association between prescription of use of gabapentin and a slightly increased risk of COPD exacerbations. And
Wow.
for those who have COPD and are on gabapentin, I haven't seen a great explanation if this is a real association, that what the mechanism might be. And I think there are some concerns around like confounding from things like smoking status and stuff. So maybe not a real association, but that's sort of like an emerging potential association.
Maybe that's why albuterol is so high in the prescribing list, is that gabapentin's causing
true.
all these
It's
prescriptions of albuterol.
It's a prescribing
Or the albuterol's
cascade.
making people anxious, and then they need gabapentin to help them sleep, and then they get the edema,
and then they're diagnosed with hypothyroidism.
Yeah, I was gonna say, and then
Yeah,
the thyroid
probably.
poops out.
yeah, it just
Yeah.
it gets incidentally diagnosed subclinical.
Yeah.
You know, one thing that I love about this episode is that I love when we do something, do an episode about something that like you really encounter in everyday life, and I would say at least once every, if not every day, then every twice a week or something like that, I see a patient who is on gabapentin. And so this is really going to stick with me. Really nice. Tony, do you have any take-home points for us?
I sure do. First is that gabapentin and pregabalin, if you haven't heard already, they have been associated with edema. And I think it's also fair to say they probably cause edema. It's not just an association. This finding leads to a very common prescribing cascade in which the prescription of one drug, here a gabapentinoid, leads to a side effect, edema, and then the later prescription of another medication, in this case, a loop diuretic. But it may be that prescribing cascade is faulty because the mechanism of gabapentinoid-induced edema is probably more related to the loss of myogenic tone than it is to sodium retention. So be wary in prescribing loop diuretic simply because your patient has new onset edema after one of these drugs is prescribed.
Word to the wise. Well, that wraps up another episode of The Curious Clinicians. Thank you as always for joining us. Claire Morgan of notorally.com is our audio editor, and Giancarlo Bonomo is our producer for the show. You can join our mailing list at curiousclinicians.com to stay up to date on episode releases and have detailed notes delivered directly to your inbox. You can subscribe to our Substack at thecuriousclinicians.substack.com, and you can watch a video of this episode on our YouTube channel, The Curious Clinicians Podcast. Physicians and other healthcare professionals can earn CME and MOC credits from VCU Health just for listening to this episode. For more information, visit ce.vcuhealth.org/curious clinicians. And as always, the information contained in this episode is for educational and entertainment purposes only and does not constitute medical advice. Until next time, we've been The Curious Clinicians.